Good afternoon. I'm Evelyn Hammonds. I'm professor of the history of science and African American studies here at Harvard. And it's my great pleasure to welcome you to today's discussion entitled Medical Racism from 1619 to the Present, History Matters. This program is a collaboration between the Program on Race and Gender in Science and Medicine at the Hutchins Center for African and African American Research here at Harvard, and also the Presidential Initiative on Harvard and the Legacy of Slavery, and of course, the Radcliffe Institute. This is a very timely topic given that the pandemic of COVID-19 is engulfing the world. And here I just want to take a note that we should all be praying for the current situation in India, and we hope that it is resolved soon. So I, like our guest historians, have been involved in many discussions over the last year where journalists and others have asked us to speak about the lessons that we can learn from the history of past epidemics to help us understand our contemporary situation. The pandemic of COVID-19, like so many other epidemics, has revealed deep and persistent racialized inequalities in US society. And in many respects, these inequalities are tied to structural racism within many US institutions, including medicine and public health. Our discussion today will focus on the history of medical racism, covering much of American history through a few episodes. And I'm very happy to welcome two of my fellow historians, Jim Downs and Susan Reverby, to share their important work on this topic. Our format is as follows. After my introductions, Jim and Susan will each speak for about 5 to 8 minutes. Then the three of us will have a conversation for about 20 minutes. And of course, then we will open up for questions from the audience. So please remember to submit your questions through the Q&A function. Now, let me introduce our speakers. Susan Reverby is the Marion Butler McLean Professor Emerita in the History of Ideas and Professor Emerita in Women's and Gender Studies at Wellesley College, and a visiting fellow in the Project on Race and Gender in Medicine and Science at the Hutchins Center for African and African Americans Research here at Harvard. Susan is a well-known historian of American medicine, nursing, race, and women. Among her many books are an edited collection, Tuskegee's Truth, Rethinking the Tuskegee Syphilis Study from 2000, and her multiple prize-winning Examining Tuskegee, the Infamous Syphilis Study and Its Legacy, 2009. In 2010, her exposure of a 1946 through 48 US Public Health Service study of inoculation syphilis in Guatemala led to a worldwide outcry, a federal apology to Guatemala, reports by bioethics commissions in the US and in Guatemala, and multiple lawsuits. Her latest book, published just in 2020, is Co-Conspirator for Justice, The Revolutionary Life of Dr. Alan Berkman. As her signature line says in her email, she is, quote, repurposed, not retired, unquote. Currently, she is working on part of the Public Health Advisory Group to release aging people in prison in New York, to push legislation on elder parole and fairer parole hearings. Our first speaker will be Jim Downs, and Jim is the Gilder Lehrman National Endowment for the Humanities Professor of Civil War Studies and History at Gettysburg College. His books include Sick from Freedom, African American Sickness and Suffering During the Civil War and Reconstruction, 2012, and currently Maladies of Empire, How Slavery, Colonialism, and War Transformed Medicine, which is forthcoming from Harvard University Press. And he's recently been named as editor of Civil War History. He's edited 6 anthologies and has published articles and essays in The Atlantic, The New Yorker, Slate, Vice, The New York Times, The Washington Post, The Chronicle of Higher Education, The LA Review of Books, and many others. Downs earned his PhD and MPhil at Columbia University, his MA in American Studies also at Columbia, and his BA in American Literature at the University of Pennsylvania. In 2015 to 16, Downs was awarded an Andrew W. Mellon New Directions Fellowship that allowed him to return to graduate school, where he gained postgraduate training in medical anthropology at Harvard University. It is now my pleasure to pass the virtual floor on to Jim Downs.
Well, first, I just want to thank Evelyn and the team at Radcliffe for inviting me to participate in this important discussion. Today, I'm going to begin by talking about two of my books in this sort of introductory comments. The first I'm going to talk about is Sick from Freedom, and this book is important in terms of our discussion today because in this monograph, I uncovered a smallpox epidemic, which until the publication of this book, historians didn't know. And so I pieced together evidence that I found from the National Archives and basically uncovered that over 60,000 freed people died at the moment of emancipation. So in order to sort of understand how this epidemic even blew up and to understand the sort of medical consequences that formerly enslaved people confronted during the Civil War and Reconstruction, we have to first understand one major important fact from the Civil War that's often overlooked. And I'm saying this now from my perch at Gettysburg College, where I ran this morning on the battlefield where tens of thousands of soldiers were killed. And that typically is the way that we remember the Civil War. It's a war in which many soldiers heroically died on the battlefields of Gettysburg, Antietam, and other theaters throughout the Civil War South and North. But in actuality, more soldiers died from disease unrelated to battle. They died from what they referred to in the 19th century as camp diseases, what we might refer to today as infectious disease. They died from dysentery, pneumonia, smallpox, yellow fever, and then later cholera. So when formerly enslaved people emancipated themselves from slavery, they entered into a world that was pillaged by death and disease. And so our typical story of emancipation is that freed people were triumphant, and they were triumphant because they broke free from slavery. But the question becomes, where did they sleep that night? Where did they eat? Where did they find shelter? They entered into an environment where more soldiers were not dying on the battlefields of Gettysburg, but they were dying of pneumonia and dysentery and other infectious disease. And without basic necessities, formerly enslaved people began falling victim to these various issues. What happens is the federal government, in an unprecedented move, create something called, and I talk about it in the book, the Medical Division of the Freedmen's Bureau. So long before the New Deal, long before the Affordable Health Care Act, the federal government did something completely surprising. They created a national system of medical care in the South in order to respond to the explosive outbreak of infectious disease. They established something close to 40 hospitals throughout the South. They employed over 40 positions, and they provided medical care to well over 1 million free people. But despite this magnificent intervention and this unprecedented intervention, a smallpox epidemic exploded at the time of emancipation. The earliest evidence that I found traces it to Washington, D.C., not too far from where Abraham Lincoln was penning the initial preliminary Emancipation Proclamation in 1862. So this is an important point. Lincoln is thinking about the Emancipation Proclamation, but he's not thinking about the humanitarian questions of how free people were going to survive. So the Emancipation Proclamation is often seen as a military necessity for the North to deplete the Southern labor force. But there were no efforts, no consideration about where free people were to find food and to find clothing. And so as a result, the smallpox epidemic explodes in Washington, D.C. Evidence of it begins to sort of appear, according to the archival record, in Virginia, later in the Carolinas in 63 and 64. By 1865, the smallpox epidemic has covered the entire South. The numbers of people dying are astounding. In the Sea Islands, which are the islands that dot the sort of coast of Charleston and Savannah, something like 800 people a week were dying of smallpox. And Washington, North Carolina, 300 people died a week. I found records in Mississippi of 550 people, Black people dying per week, compared to only 37 white people. And so throughout the surviving archival material, there is a real asymmetry. There's a sort of imbalance in the number of people who are infected. Freed people are dying at larger numbers, in large part because of the fact that people at this time are blaming the spread of the epidemic on Black people themselves. They are saying that it's because they are sort of, quote, promiscuous. And the 19th century understanding of that is that they're intermingling, men are living with women. They blame the fact that they're dirty. They come up with arguments about that they're unsanitary. They never take into account that they lack the basic necessities to survive. And that what happens is, and this is a piece of US political history and US history that we don't know, that between 1863 and 1865, formerly enslaved people are not permitted to go where they want to go. They are, according to military parlance, considered to be contraband. They are placed in refugee camps, similar to the detention camps that we see in the Southwest. They're congregated in these spaces. And then when infectious disease like smallpox blows up, it continues to accelerate among this population. And so for white people at this time, there's lots of different ideas about quarantine and vaccination and inoculation, but the most tried and true way of solving the smallpox epidemic would be to just take people that were infected and quarantine them. Now, I used to tell this history all of the time, and people didn't understand quarantine before before COVID. And as a result, at that particular time, they weren't even creating opportunities for Black people to quarantine themselves, because they were either forced to be on plantations to return to the labor force after the war, or they were in these refugee camps. So there's a lot of reasons for why the epidemic sort of explodes, and I'm happy to talk about it during the Q&A. But a question that I have, especially in light of the current COVID outbreak, is when do epidemics end? And so when did the smallpox epidemic end? And in actuality, it's hard to actually say when it ends, because in 1866, at the moment when it seems to be the rates of infection seem to be sort of dissipating, formerly enslaved people, as all Americans at this period, face a cholera pandemic. A cholera pandemic that begins in Asia, travels through Europe, and then makes its way into the United States. Formerly enslaved people are not only confronting the smallpox epidemic, they're confronting a cholera pandemic. And then on top of it, there's a drought that completely devastates the opportunities for them to return to the agricultural South and to earn a livelihood. So when we think about how do epidemics end, and we think about this bigger question, we also have to be concerned about other social and political forces that are happening. That book sort of charts, in many respects, the health conditions of formerly enslaved people. But I was really interested, when I was finished with that book, why the government was able to ultimately develop an efficacious protocol to stop the cholera pandemic from infecting both white and Black people. And that has led me to my second book, Maladies of Empire. And this book is coming out later this year in September. And this takes a different analytical position. It sort of examines the ways in which doctors learned from explosive outbreaks of epidemics among enslaved people, colonized people, conscripted soldiers, Muslim pilgrims, and many other dispossessed populations in the 19th century. And it basically says that doctors learned how to create the tools to develop the field of epidemiology. So when we think about epidemiology today, the tools that we're using to control the pandemic, those originated during the 19th century as doctors observed the spread of infectious disease among enslaved people on slave ships, on colonized people in the Caribbean and in India, and then later with soldiers both during the Crimean War and the Civil War. And the reason why I think this is really important for us today to sort of think about is that we can think in terms of the past, in the ways in which people, like formerly enslaved people, were devastated by pandemics and epidemics. But we also need to think about how, at the same time, science is learning from the wounded, science is learning from their infection, and that different forms of medical knowledge are growing out of the morbidity and mortality that affected large populations of people. So I'm going to sort of stop there. I'm going to hand it over to Susan. I'm happy to talk more during the Q&A and other points.
Okay. Hi. Good afternoon. Thank you again for this opportunity. I really appreciate it. And I'm grateful to Evelyn and to Jim for sharing this. So as the COVID pandemic raged and then the vaccines became available, there was much media discussion of the so-called mistrust of the healthcare system and government by African Americans. Over and over, the words Tuskegee and the syphilis study that took place there are mentioned. I want to briefly explain why this has happened and what the limits are of the way the terminology has been used. So let me briefly explain what actually happened. Between 1932 and 1972, the United States Public Health Service recruited these men and others like them, approximately 400 with late stage syphilis. That means they were supposedly no longer contagious, and 200 without the disease as the controls, to study what happened when the disease was left untreated, and based on the assumption that the disease was different in Blacks and whites. Instead, the men were told the aspirins, iron tonics, and vitamins they were being given, even a diagnostic spinal tap, was treatment for their bad blood, a colloquialism for syphilis and other diseases. Blood draws were taken every few years as well to check on the men, not to give them the disease, as is often claimed, often by using these photographs, particularly this one when it's cropped so that all you see is a white hand on a black arm. And even though it's a blood draw, it often looks as if he's being infected by the physician in the picture. And the families were also given money for burials if they agreed to autopsies. Nothing was actually hidden about this study. It appeared in at least a dozen medical journals over the years, and Black doctors and nurses were the primary face of the study to the men. The study only stopped in 1972 after an intrepid sexually transmitted disease investigator, horrified by it and unable to get the government to end it, gave the story to a newspaper friend. It exploded across the media, leading to a federal report, a lawsuit, congressional hearings, and lifetime health care to the remaining men and some of their wives and children. In 1997, a group of us were successful in lobbying then President Clinton for a formal apology, while a handful of the men were still alive. Ever since 1972, Tuskegee has lived on through rumors, books, plays, movies, poetry, music, and in the lessons that bioethicists teach about what not to do. Indeed, in both 2006 and again this year, Tuskegee made its way into two different Saturday night routines where African-American hesitancy around either medical care or vaccinations for COVID are spoofed. We know what this is. The characters played by Kenan Thompson and Hugh Laurie cry out in the 2006 skit, Tuskegee, 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 even when the doctor is offering routine medical care and even as if they don't have to explain anything else. The same time as the Tuskegee study was ongoing, the US also worked with the Guatemalan government in the late 1940s on the study to see if penicillin would serve as a prophylaxis for syphilis and other STDs. That is, if it could help people who already had unexposed sex, might have become infected but hadn't evinced disease yet. This study, unlike Tuskegee's, was kept hidden until I actually found and then published the details of the study in 2010. In this case, the government actually did infect prisoners, mental patients, sex workers, and soldiers in Guatemala with these diseases, including, unfortunately, and this is a pretty painful slide to show you, men's penises and women's cervixes to induce the infection. And in this picture, they're not measuring the man's penis. They're actually looking at the size of the sore that can develop when you have syphilis. When I shared my paper with the CDC, it eventually made it up the chain of command to the White House, leading to front page stories here and in Guatemala, because there was a formal apology to Guatemala from the Obama administration, a bioethics commission report, and now some ongoing lawsuits. So this slide is just a quick comparison of the two studies to just remind you about what happened in Guatemala. The subjects, both men and women, are given sexually transmitted diseases. Not all the subjects are given penicillin. Not everyone becomes infected, but not everyone is absolutely cured if they become infected. In Tuskegee, it's only African-American men who already had the disease and were supposed to be not infectious, but some of them may well have been, and their wives and sexual partners may or may not have been treated at the time. The men were supposed to be kept from treatment, although I argue my book, some of them in fact made it out. So Tuskegee, more than the study in Guatemala, however, has remained in the American political vocabulary since 1972 because there's a larger population to carry it forward, and for a series of other reasons I'd be glad to discuss. But even when invoked to somehow explain African-American quote unquote mistrust that has been revived with discussions of COVID, it is, I think, when people invoke it, a way to talk about racism, not to dwell on the history or even to know the details. For the historical lessons, I think, that are really important, and the ones that are usually ignored, are some of the following. That is, if you think about it, if there had been 30 acres and a mule, and as Jim has demonstrated, even better medical care after the Civil War, the men's families might not have stayed in Tuskegee and had other economic choices that would have led them off the land. If the men had had access to decent health insurance, they would not have been as vulnerable to the offer of the public health service of free medical care. If there had been more sex education, condoms available, and public health, there would have not been so much syphilis. If racist assumptions about biological difference hadn't existed, the study would never have been done in the first place. And I want to conclude too by reminding you that even though there were both Black doctors and nurses central to sustaining the study, we need to remember that just having racial concordant patients and healthcare providers is not enough to stop the structural problems we face. So in the end, I think we have to consider the way structures of racism get into the healthcare system and shape its outcomes, not just in the seeming memory of medical horror that ended nearly 50 years ago. And now I'm going to turn it over to Evelyn for the discussion.
Thank you, Susan. Thank you, Jim. These are your work. All of your work is absolutely fascinating and crucial. And I just wanted to start by asking both of you to think about and muse on this particular question. How does history help us in this contemporary moment? I am mindful of the fact that in this moment, at least over the last year, right? It seems that the work of historians of medicine has never been more relevant than it has been today. I mean, we've all been on numerous webinars like this. We've been on local media, international media, and this is important. And it's important that the work we've all done is finally getting, I think, quite just recognition. But at the same time, as we are right in this epidemic ourselves, how are you thinking about the role of history in this moment? Is it to be used in the ways that many journalists ask us to do, to give them the lessons from the past that's going to help us understand better the present? Or is it a way for us to help ask people to think harder about the past?
I can start if you want. So one of the things I think that's really interesting is that when we thought there was going to be a major flu pandemic in 2007, the United States government gave some money to a group of historians to look at what had happened during the 1918 to 1920 flu pandemic. Mm-hmm. And they came up with the information that's being used over and over again now about what happened with what's called pharmaceutical interventions. It's the
Yes.
fancy term for saying quarantining, closing the schools, the commerce. So the reason that the government could say we need to do this is because they used the history that had been developed that showed that people on the West Coast who closed more quickly survived better that pandemic than the people in Philadelphia who had a big parade and then everybody got sick. So one of the ways that history's been used immediately now has been using that particular set of studies. But what I think is really interesting is the same year that that paper was published, there was another paper that said, when we face a pandemic, we have to really think about who's going to be the most vulnerable and how do we reach out to them. What kind of special conditions do we need to think about? How do we manage this? That paper got ignored, which I think is really interesting. So I think one of the things we have to think about is which part of what history gets picked up. So as Evelyn and I just wrote this piece about this, about like the way Tuskegee gets used. And what we argued is, as historians who both of us have written about Tuskegee, we've noticed that people just say, oh, Black people don't trust the healthcare system. And it's because what I call sometimes the holy trinity now of 3 studies. So it's Tuskegee, what happened with Dr. Sims, who operated on slave women in the 19th century, and then the Henrietta Lacks story and the use of her cells. So all those things get thrown in as if some journalist or some medical person now understands everything that happens to Black people, and they can be really use the history to explain the problem, rather than understanding all of the structural reasons that this happened, without understanding the 2007 report that suggested if we had worked with community-based groups more quickly. So in Massachusetts, for example, we opened up these giant vaccination places in places like Gillette, which if you live in Roxbury and don't have a car, isn't so easy to get to. We didn't start the vaccinations in community centers. I have a friend who runs the Brazilian Immigrant Center, for example, here in Boston, and people who are undocumented, for example, have been using that place to get their vaccines, but it wasn't a place we started. If we had started there, we could have understood the history better, and we could have stopped some of the spread.
Right. So I would just pick up on the point that Susan said about quarantine and lockdown. So when the quarantine first and the lockdowns first got announced last March, it was basically a brand new concept to most Americans, to most people throughout the world, but not to most historians. And some of the debates that happen around quarantine, mostly this sort of balance between public health and the economy, are not new. So it was really important, I think, to have historians in the room at that moment, in large part because when the quarantine first started, it was almost treated among a lot of people, and this goes back to Susan's point, as a kind of a joke. And I don't mean for the people that oppose it, I mean even for the people that supported it. It was a time to turn, bake banana bread with their families, to turn their garages into fitness centers, people Instagramming, I like the downtime. And as a historian, I immediately thought about, as Susan said in that second paper, the most vulnerable populations that would be most affected negatively by quarantine. And I thought about, I was living in New York at the time, I was thinking about the families in public housing, 5 people living in a 1-bedroom apartment in an apartment complex shared with 100 other families using one elevator, and then being euphemistically labeled essential workers. And immediately I was freaking out about quarantine and saying, this is actually dangerous. And even in the 19th century, before germ theory and before people even understood microbiology, people argued that quarantine should have a beginning start date and a stop date. And Cuomo never had a stop date. And so on one level, you're saying, well, you don't want the infection to spread. So I'm not saying that. But what does it mean for people who are having to share an elevator, that are crowded into public housing, that are being euphemistically referred to as essential workers, who in New York City, people are banging on pans and pots saying, wow, this is such great work that you're doing. But then totally shocked when rates of infections are skyrocketing among Black and brown people. And in large part, those rates of infection I could see, without sounding like, here I have my wizard ball and I'm imagining or predicting, or even being completely negative. But as a historian, it was very clear to me, because this had happened in the past, that those marginalized populations have often been deployed in the 19th century, as my new book shows, as washerwomen, as hospital workers, and they're constantly being forced out there to do the work, but they then become the most vulnerable to the attack. So I really felt that historians could really say a lot about quarantine. And also, I felt that there was a huge, the whole thing got completely politicized. Like, if you even questioned quarantine, you were considered a conservative. And I was like, I'm not I am not a conservative. I feel like, but I was just asking some simple questions, but it had become so ideologically infused that we couldn't even ask questions. And then who suffered? Black and brown communities throughout the country. And then also, when we're talking about racism too, and I want to make sure that we're also noting this, because I thought of this when I did Sick from Freedom. Indigenous people on reservations who have been quarantined, similar to formerly enslaved people, high rates of infection are spiking among that group. And so that's another population that we weren't looking at or thinking about, because everyone was like, feeling themselves with, embracing quarantine and thinking that they were doing the right thing.
Mm-hmm, mm-hmm. Yeah, I think for me, watching and being a part of it at the same time. So of course, when I'm writing about, in my case, the history of diphtheria, that's something that's so urgent, a sense of urgency about it happened in the 19th century, right? But to think about COVID as a historian while you're in it, right? And I was often sitting and watching television and saying, that's not the right question. That's not the right question. You're not looking at this and you're not looking at that. And the question is not everybody should social distance, but what makes social distancing possible?
Right.
And who can social distance? Under what circumstances? How is that going to effectively help control the spread of the disease? And so for me, my historical questions were ones that, slowly but surely began to filter into much of the public discourse. But in the beginning, in the first instances, those were not the questions being asked. And so I think that made it feel sort of a strange kind of disjuncture for me in those early, almost about a year ago, this very week. So the second point I want us to turn to is medical racism. My colleague here at Harvard at the School of Public Health, Nancy Krieger, and her team just published an article just last week of a study that showed that if you look at over 200,000 articles published over the last 30 years in the Journal of the American Medical Association, the British Medical Journal, the Lancet, and the New England Journal of Medicine, less than 1% included the term racism anywhere in the text. And this is a stunning study. It just came out last week in Time magazine. It's also published in more detail in Health Affairs. We talk a lot about it. All three of us have examined the role of institutional and systemic racism in medicine and science. But I actually was truly shocked by this new study. And so it's asking us, I think, to think hard about whether or not this moment, where many people are claiming is a moment of racial reckoning, will be a moment of racial reckoning. Will we take what we've learned from this pandemic and actually begin to recognize the actual state of affairs in American medicine with respect to racism? And so I just wanted you all to turn to that and comment and reflect on this point.
Okay, I'll try.
Okay.
So, but I'm also an optimist, so that you have to take it from that position. But I think we're in a very different moment, and I think it's the awful, actually, conjuncture of the sort of almost pornographic envisioning of Black death constantly, either at the hands of the police. I mean, think about the way in which we all had to watch over and over the killing of George Floyd. So we're at the moment where we're both watching all of this death and we're looking at the statistics about who got sick. And so I'm hopeful that this awful moment will actually help people think going forward what medicine could and couldn't do, what causes these things. I, for example, am working with a group in New York that's involved in trying to mitigate some of the horror of mass incarceration by looking at parole reform, for example, in New York State, and particularly the paroling of elder men who have been in, and women who have been in prison for years. And so we're trying to argue that, in fact, there's a public health problem around mass incarceration. So it isn't just an issue of social justice or of anti-racism, but also public health in what happens when you keep people imprisoned, especially when there's an infectious disease, and they don't trust the way they could get the, if they're going to get vaccinated at all, they can't trust it. So I'm hoping that all of this momentum at this moment of time of both all of this death will lead to a larger discussion about what else can be done. And I think the only way that can happen, I mean, in my experience of doing this now for, geez, it must be almost 50 years. I hate to think about this. I've been doing this since the late 60s. Is for people to understand that there are things that you can actually do. Because if you just say to people, well, there are all these structures of racism, and then everybody goes, oh, you know, how can I fix the police, housing? And I think what we're seeing is different organizations and different people understanding that the old reforms didn't work, that we really actually have to do something really serious, and that we have to fight for those things. And I think there are lots more younger people who get that a lot more quickly than some of us. It took us a lot longer to get to that point. I think there are more people of color in the professions that also can help
I agree with that. Yes,
drive it. I mean, I think it's just amazing. Younger people, you know, frankly, got educated by us, and so there's multiple generations now of people who understand some of these issues. And so I'm hopeful that we are at a particular moment, but I think we've got to seize the time.
So I would just say quickly two things as in terms of moving forward and thinking about structural racism. If we think about the past, the ways in which a lot of times the medical community does in fact want to think about rates of infection among Black people are to think about infectious disease. So there will be studies about HIV/AIDS, there will be studies about sexually transmitted infections. There won't be studies as much about infant mortality or asthma or other kinds of issues that are affecting Black people that are not necessarily posing a threat to the larger public. So I think we have to be also careful about this call for, you know, including ideas about racism, and to be mindful that we shouldn't just be focusing those studies on infectious disease, but we should actually be thinking about the problems that plague Black people. Now, as far as that study is concerned, as a historian, I'm a little worried about that study based on this new book that I'm doing, that I just did on the origins of epidemiology. If I did a keyword search from 1755 to 1866, and I said, where are the Black people in the formation of epidemiology? I would have 2 articles. What I've noticed oftentimes in Thomas Trotter's work, in Stephen Hale's work as an early chemist. Stephen Hale's, I'll just give you this one example, is thinking about the use of ventilators as a way to promote the fresh supply of air. Everyone knows his final draft study. His final study is what people turn to as evidence of ventilators are important. His second draft, no one looks at, is actually a study on slave ships. And so, in other words, slavery and the enslaved people at the holds of those bottoms of those ships were useful evidence to actually prove the efficacy of ventilators. But if you just do the keyword search, you will not find that. And yet, as I uncovered in my book, the medical scientists at the time are using cases of Black people. Trotter studies scurvy. And then when he publishes account, does he say he was on the Brooks ship, the slave ship? No, he says a multitude of cases. So he then uses a clinical language that erases the subjectivity of Black people. So in other words, I think my own, and I'm not criticized to that article, because I think it's important, is to say that just because it doesn't appear in the title or in the keyword search doesn't mean that Black people, people of color, colonized people, indigenous people weren't the evidence that the medical profession is used. And then, and I think that's what I want to get. And that's what this book, I mean, that book was like, I mean, talk about trying to be a historian and a detective, was to read through those drafts. And I have to tell you, like, honestly, super huge props to Harvard University Press and to the editors there, Louise and Robinson, people that went through those records with me to check, because honestly, it was unbelievable how that actually plays out.
Well, I mean, I think what's going to happen is this study will be a springboard to different kinds of work, including the historical work that needs to be done. And the point you just made is something that all of us as historians have noted, the ways in which the sort of evidence of and the use of Black bodies to move forward medical innovation in theory and practice, but not be acknowledged in any way, shape, or form, is something that we're very familiar with. So I think putting that all together is going to give us, I think will give us a fuller and richer understanding of what has occurred and what it means to say systemic racism in medicine. We have to turn to the questions now. Oh my goodness, there are lots of them. And I will try my best to see if I can give some of the questions that we can continue to talking about the points to make. There's a question about that asked, when we look back on the current pandemic, will we see it as successful due to the vaccines, or will the narrative be that many people died unnecessarily and highlight the inequities of the US healthcare system?
Well, it depends on whether you're watching CNN or Fox News, don't you think? As the answer to that. I mean, it's a little hard. Historians hate to do predictions, right? But so I do think that because of the politics, it's going to be really hard to know what people are going to pick up. I mean, what Evelyn and I have discussed, and we're hoping that one of the things the pandemic has done is buried at least some understandings that it is something inherent in Black bodies that makes them more vulnerable to disease, that there's been so much more discussion about what Evelyn talked about and what Jim talked about, that is about what it means to be an essential worker, what it means to live in crowded housing, et cetera, and how that makes you vulnerable to illness. So we're hopeful that that will make a big difference as we go forward, and more studies will do that. I mean, at the beginning, some of you may know this, there was not even race data being kept on who was getting sick and dying with COVID, and it was only the push by epidemiologists before that actually even happened.
Jim, did you ever thought about that?
I don't have anything. Susan did great. Susan did that great. Yeah.
So I think here's one. I think some of the questions are coming together, asking about the role. This is sort of in your lane, Susan, about how to think about the role of Black health professionals with respect to Tuskegee, and you made also a point about moving forward. So do you want to comment on that, Susan, and then I'll try to find one that fits more in Jim's lane?
Right. I mean, we all know, for example, that that it makes a difference. We know that there are studies that show if people have racially concordant physicians or nurses or health personnel, that it helps them feel more comfortable, sometimes get better care, but sometimes not get better care. It depends on where people are. Tuskegee would not have happened, as all of us know who've written on the history, if the African-American physician at Tuskegee, at the hospital in Tuskegee, if an African-American nurse named Eunice Rivers Laurie had not been the go-between the men and the public health service. And we all know that every oppressed group has people in it who are the go-betweens, them and the oppressors, and that's always been true. On the other hand, I think it really matters if places where people feel that they are getting trustworthy care really helps make a difference. So I think that does matter. I mean, as I said, like the example of the shots being given, vaccinations being given at the Brazilian Immigrant Center, for example, or in local churches. And community centers makes a big difference, and people feel somewhat safer. But I think that it's just that it's no guarantee. We used to say long before issues around trans and gender in the women's movement, we used to say all all sisters are women, but not all women are sisters. And I think it's that concept about, you know, the gender, as we well know, gender and skin tone doesn't always guarantee that people's consciousness really matters. As someone once said, it isn't, you know, when we had these arguments in the women's movement about things like this, we used to say, it doesn't matter who you want to sleep with, it's who you're willing to die for that actually matters.
The great political line.
Yeah, really.
So here's a question for you, Jim. I'm interested in how Professor Downs is thinking about the ways in which doctors use the infection of racialized bodies to construct epidemiology within the context of such racialized science. So maybe also as the 19th century saw a shift in disease theory from miasma to microbes. So, you know, so I think the question is pointing to that there was already an kind of pre-existing notion of bodies that have been racialized, and how did the doctors actually, how do you think about the ways in which the doctors use this pre-existing notion of racial differences in bodies to construct epidemiology? I know that's your whole book, but maybe
Right.
a brief answer.
Yeah, so just the quick answer would be to just sort of think about how things like slavery all of a sudden created conditions that allow doctors to observe the spread of infectious disease among large populations of people. So how did a slave ship or a colonial plantation in Jamaica allow doctors to witness the spread of an epidemic and to sort of test what protocols worked and which didn't? And so oftentimes these doctors in Jamaica and even in India and parts of the Mediterranean are looking at sanitation, and they're trying to sort of think about how unsanitary environments lead to the spread of disease. And they're not necessarily falling back on this notion of the racialized body. They're actually saying it's a result of polluted water, or they're looking at how does an epidemic all of a sudden start and then how does it end? And so what happens is that in a plantation in Jamaica, they're able to observe it in a way that they can't observe it in the UK. And so what happens ultimately with the Civil War is that the doctors in the American Civil War learned from Florence Nightingale and the British epidemiologists, but then they insist that there's a difference about racial bodies, and they make an argument about racial bodies. But the early cast of these doctors are more interested in the fact that slavery and colonialism and war have created these new social environments, because prior to this, where would we see these new social environments? Tenement houses hadn't been constructed yet. And so these new built environments are allowing doctors to witness the spread of infection. So they're counting the number infected, they're counting the number who survived, they're thinking about preventative protocols. So it's less about the individual body and more about the collective body. And what was surprising to me was that they weren't actually making this kind of argument about the racialized body. And so what my book is also trying to say is that we have to think about the notion of the racialized body appears at certain moments within the history of medicine. It's not a constant. It's definitely something in the 1890s. It's definitely something at the bell curve in the 1980s. I mean, it happens, but when doctors are trying to develop epidemiological ideas, they're more concerned about the environment.
Okay, thank you. I think this is a good question for us. The question is, can you speak to how historians can also make clear that there were people who spoke up in the past, not just now, about the impacts of racism on health? So to make clear that there's no excuse, as is oft stated now, that this is just how people thought back then. We really shouldn't be imposing our president's ideas on what happened in the past, but really speak to how the long histories of racism in health make clear why structural approaches are needed for repair and prevention.
Right. So I think one of the recovery processes that we have done as historians is to highlight that there were always these kinds of conversations. I mean, you know, you could make an argument that W.E. Du Bois should be known as an epidemiologist as well as one of the fathers of American sociology. I could make that argument that his studies on healthcare looked at all of the structural reasons, that there have been people all along who have said, look, the reason we're sick or this is happening is because of housing or racism, or we can't get to a physician. So none of this is new. And I think one of the things that's really important is to teach that. I've taught a course, for example, on the history of health activism that tried to look at this over time. I have colleagues at Columbia at the Public Health School who also teach that. So I think those kinds of questions of where does change come from in the healthcare system, as in all political life? What's the relationship between activism and social change in health? So just to plug for a second, the book that I just finished called Co-Conspirator for Justice, the physician I wrote about toward the end of his life was involved in HIV care. And what he realized at the turn of the into 2000 was that there was all this discussion about the need for prevention, but treatment was happening in the global north, but not in the global south. And so he organized a group in New York called Health Gap, the Health Global Access Project, that worked with something called the Treatment Action Campaign in South Africa. Between those two groups started to cooperate, and they pushed to change what was happening around intellectual property, around the ownership of the antiretrovirals, and made it possible for generics to be made so that eventually they could get into the global south. And the group that he started 20 years ago is still operating, and today actually was part of a rally in New York, in Washington, around the issue we're facing again, which is how do we stop the control of the intellectual property on the vaccines so that they can get into places like India and South Africa much faster.
Yeah, exactly.
So I would just give examples from my first book and my second book. So Alexander Augusta, in my book Sick from Freedom, was a Black doctor who traveled from Canada, went down to Savannah in order to basically set up a freedmen's hospital for newly emancipated slaves. And what he did was he argued against the fact that natural causes, or the natural racialized body, was the reason for high rates of smallpox infection. And he pointed to the fact that the sanitary conditions and the poor housing conditions often resulted from it. And then in my most recent book, I was actually surprised by this. Thomas Trotter, who wrote about scurvy and wrote about all of the enslaved Africans dying at the bottom of the slave ships, actually testified to the British government about how the institution of slavery had an effect on the mind of Black people that then made them susceptible to disease. So he actually gave a very sympathetic understanding. I mean, he eventually becomes an abolitionist, but he be a very sympathetic understanding of why they were dying. And it was a result of the fact that slavery had done such harm to their mental and emotional outlook that it made them susceptible to disease. So you're right, there are these examples of people in the past who are saying, wait a minute, we can't sort of fall into this traditional way of thinking of innate vulnerability, and we need to actually look at what's causing high rates of infection. And it's often structural forces, in the same way that we're seeing COVID cases increasing. I mean, because I think one of the pieces I just want to add, because when we talk about racism and medical racism, we also have to be talking about class, because this is not just race, we're also seeing class in the COVID epidemic, but we're just calling it race. And
which we have to be careful to make distinct. Yes.
Right. It's actually both. Right. It's actually both. Right.
Thank you. So this is a question I think is a good one to end on in the last few minutes that we have. The audience member asked, it is always a struggle to deal with the question of the purpose of using history and how we use it. And how would your panelists suggest we use this history? Should we use it in a targeted way and at specific times to understand specific issues? Or should this history be told and known widely? And if known widely, how do we answer the question, to what end? And let me take a stab at that one.
Wow. Good for you.
I actually think, I mean, I'm a big proponent that this history needs to be known widely and understood in the broadest possible context of American history. I think it's important to know the history in order to understand how to think through challenges that face us in the present, to understand that we can make change. Change has happened over time, as historians are constantly worried about and thinking about. And I think that the thought that change can happen over time is something that can easily get lost. And that's why understanding the history, there always have been voices speaking out against particular forms of bias and discrimination, certainly in medicine and in science. It's important for us to know now what those voices, the claims that those voices made. I think those are important parts. But it also, I think, deeply helps us to understand that we can, we can do things differently. We are not bound by what appears to be structures that seem unchangeable and unavoidable. And so that, for me, is why the history matters. So let each of you have a word on that.
I was going to say, if you think about the political storm around the New York Times' 1619 project that has happened, that is an attempt to retell American history, not from 1776, but from 1619. It tells you how powerful this history is and how afraid those in power are of our telling the truth. And so I think we have to make attempts to do, I mean, one of the things that's been great, actually, frankly, about Zoom is that we can reach, lots more people on these kinds of things or on podcasts than we could if we just gave a talk, in an auditorium with 300 people in it, for example. So I think this is an opportunity for us to use this moment to do more popular versions as much as possible, to speak in multiple kinds of forms. I think it's really interesting that Nancy Krieger's group published both in Health Affairs, that goes out to sort of healthcare professionals, and in Time Magazine at the same time, I think is really interesting and important. And I am a firm believer that we have to write really careful histories for each other and for the details, but then we can take that material and make popular forms. Jim, maybe you should talk a little bit about what you're doing around that kind of work, but I think that that's really crucial.
Right. So a couple of things. I'm working with Susan on a larger documentary on race and medicine. So that's one way of doing it. And I have done different sort of publishing and trade places, mainstream places, to have that information widely disseminated. But I actually think the solution is really simple. It can just be added to existing curriculum. And when I talk about my book, I'm often uncomfortable in one way. You wouldn't think it if you just watched the first 15 minutes. You'd be like, that guy's really self-aggrandizing. But in actuality,
Tim, I'm gonna ask you to be succinct, because
okay. All I'm thinking about is you just need one sentence. There was a smallpox epidemic. That's it. That's just one sentence added to an existing textbook chapter. And so it's really easy to just add this material to existing textbook curricula.
Thank you. Thank you both. This has been a wonderful conversation. Before we close, I want to thank the members of the Radcliffe Institute Leadership Society and the annual donors who are watching this afternoon, and we appreciate your generosity in supporting the programming that makes this kind of programming available to the public, and we thank you. And also, please, I thank Jim and Susan for always having an engaging and enlightening and thoughtful conversation and responding to the questions as well. And also thank to the audience. Oh my goodness, there was no way we could get to all the questions that we had this afternoon, but it just shows that I think that these kinds of questions that we're asking about the role of history while we're all living in the midst of a pandemic are raising many interesting and important things that we need to continue to talk about. So thank you very much. And I hope you have a good afternoon.